Hello, everyone. Welcome back to another session for our NCLEX review. We are on day 59 out of the 90 days, and we are welcome you again for those who are regular attendees and those newbies in our channel. Kindly check in our description box below. If you are reviewing for the NCLEX, we are recommending you to enroll into our NCLEX course. We have that offering that will be available for you for that entire 6 months. And we have the test bank, about 3,000 NCLEX test questions, and also the 200 NGN questions. And we also have the on-demand video library that we had just recently upgraded. And so please take note of those. And again, if you find this video helpful, kindly click the like button, and also don't forget to subscribe in our channel and share this to your friends who are also preparing for the NCLEX. Again, everyone, welcome back to our class today. We have Mary, Adobe, Felix, AJ, Eileen, Joyce. So for today, guys, we're going to talk about that topic on traumatic brain injury and also the management of increased intracranial pressure. So hang tight. All right, so let's move right into the topic right now, which is basically the TBI. And this is something that can occur when there is an injury wherein the body's or the normal brain function is disrupted. And this is caused by the trauma-related type of injury. And this will impair the neurological function of our patient. It could be either localized or it could be widespread manifestation. And the most common cause of the TBI is the falls, and this is going to be followed by the motor vehicular accidents. And the TBI is the primary cause of trauma-related deaths in the US, and it about 40% it constitutes to trauma-related injuries as well. Now, as we know that the primary goal of treating the TBI is to prevent secondary brain damage, and also we need to provide them supportive care to prevent those complications as well. Now, let's talk about the different types of traumatic brain injury. Okay, we are not going to have to talk about everything in detail, but we're just going to breeze through the different types. And of course, we are having the concussion, which is basically a temporary disturbance in the brain function. And this is going to be caused by a blow to the head. When the person has the concussion, there's no visible damage on the brain scans. Alex Smith. All right, welcome. And also we have Melrose. All right, guys, welcome back for those who are regular attendees and also newbies as well. Now, for a person that have the concussion, the manifestations here can vary greatly. They can have the headache, might have dizziness, maybe confused, or they might have the nausea and vomiting, or they could temporarily lose their consciousness at some point. Now, there could be some significant memory loss at the time of the injury, and they might also manifest the difficulty in concentrating. When a person will have the concussion, the manifestations here will usually resolve without any lasting effects. So take note about that. There's no visible injury in this person. Okay, when you're assessing, there's no visible injury. What you're going to have to take note are those subjective findings. They're going to complain about the headache, dizziness, confusion, nausea, and also they might have that temporary loss of consciousness. And when you're going to ask them about the event, they might not be able to tell you exactly what happened. Now, when we're going to encounter a person that might have the cerebral contusion, this is basically the bruising on the brain tissue, and it will lead to the swelling of the brain as well. Now, at this point, they might have some changes in their level of consciousness. They might end up with confusion, disorientation. They might be sleepy. They might be dizzy as well. And also the coordination can be affected. They might not be able to walk steadily after the event or right after the event. And in some cases, they probably would manifest the seizures or could be localized weakness or numbness into an extremity. Now, again, the manifestations here can vary depending on the location and also the severity of the bruising in the brain tissue. Now, take note, guys, we have number 3 here, which is the intracerebral hematoma. So what is this? This is the bleeding within the brain tissue itself, and this can also lead to the swelling and also increasing pressure in the brain. And I'm talking about the intracranial pressure. So when they have the intracerebral hematoma, well, they will have the severe headache, also the nausea, vomiting, they might lose consciousness, weakness as well, numbness, and they might have a dysarthria or difficulty in speaking, or they might have that difficulty in understanding what you're talking to them or what you're telling them. And they might also have the visual problems. And in some cases, in severe cases, they probably would have the seizures as well. And again, the severity and also the size and the location of the hematoma can also make those signs and symptoms more varied. Okay, now let's talk about the epidural hematoma. What is this? This is the bleeding between the skull and the outer covering of the brain, which is the dura. And this is caused by the tear in an artery and due to the skull fracture. Again, the epidural hematoma is the bleeding between the skull and the dura, which is the outer covering. And if you're wondering, what are those signs and symptoms? Yeah, they are going to end up with loss of consciousness that will be short, brief loss of consciousness, and they might have that lucid interval right after that. They might feel fine, but in some cases, if the extent of the injury is much more severe, then they probably will have some rapid deterioration as well, accompanied with a severe headache, nausea, vomiting, also drowsiness and confusion. Now, when you're looking into the pupil of this patient with the epidural hematoma, you got to pay attention here when you are using that pen light. What you're going to see here is that one side of the pupil will have the larger one, meaning it doesn't really respond to the light. So this is what we call as anisocoria. All right. So the patient also will have weakness on the opposite side of the body, which is can be life-threatening as well, of course. With a hematoma, their breathing as well can be affected, right? Now, for the subdural hematoma, what do you think about this one? This is now the bleeding between the dura and the arachnoid layers of the brain covering. And this is, of course, caused by the tearing of the veins. Now, what do you think are the clinical symptoms? Of course, they will complain about headache, severe headache. They'll get confused, disoriented. Their behavior will change. There's still nausea and vomiting in this person. They will have lethargy, weakness, and in severe cases, they will have the seizures as well, and they will have the loss of consciousness. And again, the manifestations here in a person with a subdural hematoma may appear immediately after the injury has occurred, or it could be a gradual, in a sense, over days to a few weeks. Now let's talk about another one, which is what we call as the shear injury, or known as the diffuse axonal injury, or the DAI. So this is going to cause some widespread injury into the brain's axons. And of course, this is brought about by the severe shaking or rotational forces exerted into the brain. Now, what are the manifestations here? They're going to end up with loss of consciousness that will be immediate, and to a severe extent, they will become comatose, or could be in a vegetative state as well. But at some point, if the injury is not too severe, or right after they recover, they might have some problems in their coordination and also their balance. The cognitive function is also affected. Their personality will also be altered around this time. For this person with DAI, this can often result into much more lasting damage. So they will have poor prognosis. Now, this time, guys, let's talk about the different mechanisms of the brain or traumatic brain injury. So let's talk about the cellular changes. What are those changes? Well, when this person has this traumatic brain injury, they're going to end up with the release of those oxygen-free radicals, the neurotransmitters. There will be loss of the calcium and increasing lactic acid, as we know that the perfusion of the brain will be affected. And of course, the brain cells will end up with the production of the lactic acid. And so this can also lead to neurological deficits, wherein the person will have some low blood pressure and also anemia, and their oxygenation will also go down, possibly a high carbon dioxide level in their bloodstream as well. And another effect that we're going to anticipate here would be the coagulopathies. What is this? Well, when they have the traumatic brain injury, this is going to cause the release of the intracranial thromboplastin. Take note of that. Why are they going to be prone to the bleeding? Intracranial thromboplastin. This patient will have an increase in their PTT and the fibrinogen levels, and they will end up with the clotting disorders that could range from mild bleeding into possibly DIC. Mild bleed to a severe form, which is the DIC. Now take note, guys, there's also what we call as the paroxysmal sympathetic hyperactivity. So what is this? This is what we refer to as the sympathetic storming, wherein this can lead to the uncontrolled release of the sympathetic hormones in response to the stress. So at this point, they will end up with the rapid heart rate. Their breathing will become faster. The temperature will rise. They will end up with sweating, get agitated, and there will be pronounced muscle contractions. Again, this is what we call as the sympathetic storm. And again, this is the sudden release that is uncontrolled, and we are referring to the sympathetic hormones. So that's why it's referred to as the sympathetic storm. Now take note, guys, that aside from that, with a brain injury, we will anticipate that they might either have the diabetes insipidus or could be the SIADH. But we'll talk first about the diabetes insipidus. This is involving the reduced secretion of the antidiuretic hormone, wherein this could lead to excessive losses of fluids and also electrolytes through the urination, right? And this is caused by the brain swelling and also the compression of the pituitary gland, also the hypothalamic region. So let me just indicate it right here. Pituitary gland compression. And also the hypothalamic region. So again, the person here will be at risk in the massive diuresis of fluids and also with electrolytes through the kidneys. Now take note that the person may also have the exact opposite, which is the SIADH. Let's have that one right here. Let me erase this. The syndrome of inappropriate antidiuretic hormone. Well, if the injury will cause the exact opposite, this is going to allow the overproduction of the antidiuretic hormone. So, an oversecretion or overproduction of the ADH can allow the massive reabsorption of the fluids from the renal kidney tubules or renal tubules. These will be reabsorbed into the circulation, and our patient will end up with hypervolemia and there was going to be dilutional hyponatremia, hypervolemia, and it can lead to a severe drop in the sodium level because of the dilution. Now, of course, with a dilution, it can also cause the fluid to get into the brain cells, causing more of that cerebral edema. Please take note of that. Now, there's also an issue, and in this will be what we call as the cerebral salt wasting, and this is going to involve the increased loss of sodium in the urine, and this is what we call as natriuresis. Natriuresis, which is the excessive excretion of the sodium in the urine, and also this will be accompanied by a massive reduction in the fluid volume, because as we know, that fluid will follow where the sodium goes. Again, this is what we call as the natriuresis, or excessive cerebral salt wasting. Now, let's talk about, yes, they're going to end up with a dehydration. Now, let's talk about the different assessment findings here, especially in this patient with the traumatic brain injury. So let's talk about the disturbances in their consciousness. It could range from just confusion, disorientation, or it could be worse, coma. And this is going to affect the brain's ability to maintain that normal levels of consciousness. And they probably will be associated with the disorientation as well as to the place, time, events. And also it can occur due to the brain's damage and to those important structures that regulate the alertness and also the awareness. Now, take note, guys, that when you have a patient with a TBI, they will manifest the headache or it could be the vertigo. This is going to happen when there is swelling, increasing pressure inside the brain, or it could be caused by the direct damage into the areas controlling the balance and pain perception. That's why they're going to end up with the vertigo. Now, the person right here will also be complaining, or they will manifest some restlessness, agitation, because of the disruption in the area of the brain where they're able to control their emotions, and they're not going to be able to really control those impulses. And that is why the restlessness and agitation can be manifested, or it could be caused by the low oxygen as well. So not just about the dysfunction in the regulation of the impulses, but also the low oxygenation. Now, please take note, guys, that the patient might experience some irregular respiration, because we know that the brainstem, this is supposed to control those basic life functions, such as the breathing, which is often affected by the TBI. And your patient now will have irregular respirations, or they could probably assessed with some tachypnea or bradypnea or even apnea. Again, this will be irregular. Now, take note that with a patient with a TBI, their cognitive function will also be impaired. And again, this is dependent on the severity, right? And also the location of the injury. So the patient will have some confusion. They probably have some deficits in their speech. Could be expressive aphasia. They might have some problem in comprehending what they are reading. Or they could probably have issues with their memory. They probably would have the retrograde amnesia, wherein they're not going to be able to recall past information, or maybe anterograde amnesia. So it could be either retrograde amnesia and also anterograde amnesia. So this is going to be about memory loss, past events. Anterograde is the inability to form new memories. New events, impairment in their memory function, anterograde and retrograde. Now, take note, guys, that when you are going to check in their pupils, you will be seeing the inequality in their pupil size. When you are shining that pen light, they're going to have the anisocoria, or it could be sluggishness into the pupillary reaction, and this is indicating the brain injury, especially if there is excess pressure into the optic nerves, or if this is causing pressure into the brainstem itself. So take note about the optic nerve, or it could be the brainstem. So again, your patient will have sluggishness and also inequality in their pupil size when you are eliciting the pupillary reflex. Now, the patient will also have some sudden onset of neurological deficits, and this could range from weakness in their muscle, could be numbness, could be paralysis, and this can occur maybe on one side of the body, and this is caused by the damage to the specific brain regions that control the motor and sensory functions as well. Now, with a TBI, coma can happen, especially if there is severe injury to the brain, wherein the patient will have a prolonged state of unconsciousness. And of course, there will be some different levels of the unresponsiveness according to the extent of the injury. Now, take note, guys, that our patient will probably have some otorrhea or the rhinorrhea. And please take note, this is the drainage of the CSF from the ears. CSF from the ears, or the drainage of CSF coming from the nose. And of course, this is suggesting that there is now fracture at the base of the skull. And when there is that fracture, this is now going to allow the drainage or escape or leakage of the CSF into the skull openings where the fracture is. Now, here, this is also going to manifest those raccoon's eyes and battle signs. Take note into these two pictures right here. You'll see that purplish or like black discoloration surrounding both eyes. This is what we refer to as the raccoon eyes or the battle signs. There's going to be bruising, discoloration behind the ear, and they are indicative of the skull base fractures, and they are a result of the blood that's actually draining into the soft tissue spaces following the fracture. Again, this could be caused by maybe blunt injury, could be head trauma, or maybe fall. But you will really take note of the discoloration around the eye, surrounding the eyes, and also behind the ear. And again, don't forget about the raccoon eyes and the battle sign. Now, the person here with the TBI will also have the sympathetic storm. Like I've said earlier, there's that uncontrolled release of the sympathetic hormone, which will lead to episodes of altered LOC. They're going to have tachycardia, rapid breathing. Their temperature will go skyrocketing, and they will get agitated as well because of the uncontrolled release of those sympathetic hormones. Again, the catecholamines, right? Now, the patient here with the TBI will also have the abnormal bleeding, or what we have earlier as the coagulopathy. Again, this is going to allow the coagulation disorder. The patient will end up with increasing prothrombin time. And of course, this is brought about by the release of the tissue factors that will disrupt the normal blood clotting mechanism. Now, we also have a patient here that might manifest the cardiac dysrhythmias. And again, this is caused by the release of those catecholamines, those stress hormones. And so their heart rhythm will probably range from irregular heartbeats, maybe bradycardia, tachycardia. And this is because of the brain's influence into the autonomic nervous system, which control the heart rate and the rhythm. Now, this time, guys, let's talk about the treatment, overall treatment about the TBI. So first things first, we're going to make sure that our patient maintains airway. Make sure that it's patent. And also, if they're not really responsive, they're unconscious, this is going to impair their airway and also their breathing. So take note, guys, if the patient is going to be unresponsive and if their oxygenation is already compromised, then there's a need for us to get ready in the intubation. All right. Now, also with the breathing support, the patient will require here mechanical ventilation. Of course, if they are comatose, if their GCS score is less than 8, 8 or less, indicating that they have severe unconsciousness, or if there are signs of breathing issues. Now, the patient here will actually get a need to have that supplemental oxygen as well to ensure that our patient is maintaining adequate perfusion to the vital organs in the body. And here, when we are managing the patient's oxygenation, we want to make sure that the blood O2 levels is above 100% or 100 mmHg, and making sure that the carbon dioxide levels is between 35 to 45 mmHg. And we really don't want to place the patient in hyperventilation, because this can cause a lack of CO2. And we know that if there is a lack of the CO2, this can lead into the vasodilation, which can also complicate the cerebral edema. It can also lead to increase in the ICP. Now, guys, when your patient probably have issue with their breathing or airway, a tracheostomy might be an alternative, wherein there's going to be an incision to be done, especially if the intubation is, if it is expected to last more than 2 weeks, then a tracheostomy would be an alternative. Now, as part of the management here, we really need to make sure that we are also monitoring the patient's circulation, make sure that we are avoiding hypotension. We want to make sure that our patient's blood pressure is above 90 mmHg, okay? At least. And of course, this will be managed by the administration of IV fluids, or could be the vasopressors. We want to make sure that they have adequate circulating volume. And of course, if the patient will end up with volumes of IV fluids replacement, they probably would have some dilutional anemia. So this is something that we're going to have to treat as well. If they're going to end up with delusional anemia, packed red blood cells would be also be part of the treatment if there is a sudden drop in the red blood cell or hemoglobin. Now, if there's going to be irregular heartbeats or arrhythmias, that could really compromise the oxygenation and also the overall function, then this is supposed to be treated as well. Now, take note that with a TBI, ICP monitoring is one of the mainstays. We're going to make sure that this is monitored properly, and with the positioning of our patient, make sure that we are administering those prescribed meds to reduce the brain swelling. Now, take note that our patient, possibly after the surgical procedure, if they probably had burr or could be the removal of that fracture that is causing pressure into the brain tissue, headache is basically one of those manifestations. So our patient will be given those opioids, but you got to be cautious, especially if they are going to cause respiratory depression, and we really don't want that. And so you have to use your judgment, especially in the administration of those medications. Now, if the patient will end up with high blood pressure post-op, then we're going to control that with the beta blockers, or it could be the clonidine to reduce the high blood pressure. If there is going to be some spasms, muscle spasms, then one of the treatments would be the dantrolene, or it could be the amantadine to at least um, reduce this manifestation as well. Now let's talk about the supportive care that we should be performing to those patients. Well, of course, rehabilitation is key in our recovery here. And so we will be providing nutritional support, and this is something that we will keep in mind, especially after 3 or within 3 to 5 days after the brain or traumatic brain injury. We will normally resume the feeding, and this is going to be started by the nasogastric tube feeding to make sure that our patient's nutrition is supported. Make sure that possibly if they are at risk to, if they probably would need the feeding, the artificial feeding, then they might have, or the medical provider might have an alternative, maybe the placement of a gastrostomy tube, if the feeding will last more than 1 to 2 weeks. Okay, that would be the nasogastric tube, or could be the gastrostomy tube. The gastrostomy tube will be an alternative if the patient will require feeding, enteral feeding that could last more than 1 to 2 weeks. And this will be a lot safer compared to the NG tube because of the disadvantages. It can get easily dislodged. There's so many complications that can also arise when we are not really carefully monitoring our patient with a nasogastric tube. So gastrostomy tube would be a lot safer compared to the former. Now, if your patient has significant injury, if there is going to be skull fracture, there's going to be drainage of the CSF, they are prone to getting those opportunistic infections. And so they will require the use of antibiotics if there's surgical procedure, especially if there is evacuation of hematoma, or let's say if they're trying to fix the fracture in the skull, or if they're going to at least put some tubes in to help drain the cerebrospinal fluid, like let's say ventriculostomy, or the placement of that drainage tube, which is the EVD, then definitely our patient will be prone to developing those opportunistic infections. So antibiotics will be one of those treatments. Now, in general, our patient might end up with the hypernatremia. This is an imbalance caused by the diabetes insipidus. Remember about that one when I mentioned about the DI? The patient will have no control in the excretion of the fluids. They don't have any control in the excretion of the other electrolytes. But here, when the patient has excessive urination because of the lack of ADH, they're going to end up with hypernatremia, hemoconcentration in the blood. So anything like that greater than 145 milliequivalents, and most often probably about 150, 160, they're going to be so at risk to developing neurological impairment as well, and consciousness because of the hypernatremia. So what are we going to do with this patient if they have hypernatremia, especially if it is complicated with the increasing ICP? That is quite complicated. So how are we going to deal with the hypernatremia in a patient with ICP increase? Well, the correction here will be gradual. You're not going to treat this patient rapidly. There should be gradual correction. And of course, the monitoring of the electrolytes will be done as well to make sure that we are not correcting the patient's sodium level so rapidly. Now, the goal of the reduction in the sodium should not be more than 10 to 12 milliequivalents per day. If they have hypernatremia, like I have said, if they have hypernatremia as a result of the DI, our correction should not be done rapidly. Again, if let's say, for example, if the sodium level is about 157, okay? So we should not be correcting that, or we should not lower the sodium level so rapidly that could be greater than 10 to 12 milliequivalents per day. So anything greater than, or maybe 157, so let's have maybe 147. So 147, a drop of 147 is actually our allowed limit in decreasing that sodium level, or else our patient might end up with neurological impairment as well. So make sure that it doesn't exceed the correction of 10 to 12 milliequivalents per liter in a day. Okay. Now, on the other end, if our patient will have the hyponatremia, the same thing. We are going to correct that slowly. Nothing more than 8 milliequivalents or 10 milliequivalents in a day, because it can lead to the osmotic demyelination syndrome. Okay, for this patient with a hyponatremia as a result to the syndrome of inappropriate antidiuretic hormone. Again, our correction for the hyponatremia, when we are giving them the hypertonic saline solution, then we have to gradually correct that as well. Nothing greater than 10 milliequivalents per liter per day to prevent the ODS, which is the osmotic demyelination syndrome. And this is going to cause some permanent damage. The patient will have quadriplegia. It can also impair their speech. They will become disoriented, confused, and so many other neurological manifestations. Again, when you're correcting electrolyte imbalances in a person with a TBI, you have to gradually correct the hyper or hyponatremia. Now let's talk about the increased ICP, since we are actually going to deal with this condition in our test questions today. This is basically the increase of the pressure inside the brain, inside the skull, and also the brain tissue, because of the force exerted from all the components within the cranium, right? We have the cerebrospinal fluid, we have the blood, the gray matter, white matter, and also the different components. And so if the person will have a TBI with the swelling and everything, maybe bleed that might have accompanied the TBI, then this can occupy a good amount of space inside the brain. And as we know, guys, that our ICP, do you remember the range of the ICP? The ICP usually is around 5 and 15, between 5 to 15 mmHg. All right, take note about the range. Now, if the person will have elevation greater than 15 or greater than 20, this is going to cause some changes, neurological changes in our patient. It simply means that there is probably swelling, bleeding going on, or maybe a fracture that is causing pressure into the brain tissue. This is caused by so many contributory factors. And of course, trauma, traumatic brain injury is one, hemorrhage, aneurysm rupture, or it could be stroke. Patients that might have hypertension, hypertensive crisis, maybe a tumor that is occupying space in the brain, or it could be the hydrocephalus, wherein the person will not be able to really have that capacity to regulate the outflow of their CSF in the ventricles, or it could be the cerebral edema or inflammation, maybe because of some infection going on. Now, take note, guys, that our patient with increasing ICP will have a decrease in the circulation in the brain tissue. Please take note of that. When they have increasing ICP, the blood supply to the brain itself will be markedly reduced. So if we are not going to control the increased ICP timely, yeah, this can lead to anoxia and could lead to permanent brain dysfunction. Now, another complication here with increasing ICP is the slowed absorption of the cerebrospinal fluid. And also, guys, this will alter the nerve cell function and make sure we are also assessing the patient for any signs of brain herniation. And we'll know more about these assessment findings here. So here we go. What are the manifestations in a patient with increasing ICP? Take note, there's many. What are those? Well, we have here our mnemonic or acronym Cheese Piper. Okay, please take note of the acronym Cheese Piper. C stands for changes in LOC. It can range from drowsiness to coma. This is the earliest manifestation, changes in the level of consciousness. We also have the headache, hemiplegia. All right, the hemiplegia is going to be a late sign. All right, what else? There's going to be an elevation of the systolic blood pressure. This is also a late sign. Okay, as we know that there will be some compensatory mechanisms that will occur when there is a brain injury. There's also elevation of the temperature, hyperthermia, as we know that there is the uncontrolled release of the sympathetic hormone, the catecholamine. Yeah, remember about that. There's also slowing down of the heart rate, which is part of the Cushing triad. This is a late sign, the bradycardia. And of course, with the emesis, this can happen because of the possible involvement with the vomiting center in the brain caused by the increasing ICP. Our patient will have posturing, starting with the decortication and leading into the decerebration. There's also irregular respirations, which is basically part of the Cushing triad. So take note about the I. There's also widening of the pulse pressure. So our patient here will have systolic hypertension. Systolic hypertension, but the difference between the systolic and the diastolic will be greatly increased. All right, it will be a lot wider. The patient will also have edema of the optic disc when the medical provider will be looking into the pupils or inside the eye using that ophthalmoscope. There's going to be edema into those microscopic capillaries, and this is caused by the increasing intracranial pressure. And the patient here will develop that Babinski reflex if this is going to cause much more severe injury into the brain structures. So don't forget about the Cheese Piper. I hope that this will help you recall the important manifestations. Now let's talk about the treatment of the increasing ICP. Well, of course, neurological assessment should be done, right? Much more frequently this time. So this will include checking the patient's level of consciousness, the pupillary reactions. We're going to have to use the Glasgow Coma Scale more often this time to detect those changes, to check if the patient will have probably a rapid, what do you call this? If there is going to be a rapid worsening of their manifestations, if they could probably be at a scale of 15 and then in a few minutes, maybe a few hours later on, their GCS score probably would go downhill. And so this is something that we need to capture. Another treatment here, or your nursing care for this patient that has an increasing ICP, would be to put them in a semi-Fowler's position, and this is going to help drain the fluids, especially. It will decrease the brain swelling as well. What else? Avoiding the Trendelenburg's position. Yeah, of course. When you're going to put the head down, This will definitely lead to increasing ICP as well. We need to do that external ventricular drain, EVD. What is this? This is going to be a procedure that is invasive that will allow insertion of the tube. And this is going to allow us to measure their intracranial pressure as well. And I'll be showing you that in a minute. Now, when a patient that has an increased ICP, it is very important that we are decreasing their stimulus or stimuli, because with that, it can also lead to increasing ICP. If there's so much noise, where there's so much traffic in the room, then those would need to be managed as well. What else? We're going to have to manage this patient by controlling or avoiding any kind of straining, especially if there's coughing or sneezing. Those are things that need to be avoided by the patient. So these are known to increase the ICP as well. Even suctioning, especially if you're going to do your nasotracheal suctioning, you got to be cautious with that because it can also stimulate increase in ICP. What else? Avoiding Valsalva's maneuver. This can also lead to increasing ICP. Flexion of the neck and also flexion of the hips should be avoided because these are known to increase ICP as well. Or if you are allowing the patient to bend their knees, or maybe there's a pillow behind their knees when they're in bed, this can increase the intra-abdominal pressure, and this will also lead to the ICP increase. So please take note of that. So here, guys, you see this photo right here. We got the EVD. Let's take a peek real quick. So this is going to involve the insertion of the tube. This is what we call as the external ventricular drain, or EVD, which is used to manage, or if there is an increasing ICP, we are going to monitor their pressure as well. And this is used to drain their CSF as well from the brain's ventricles. Now, this is a procedure that will involve the insertion of a catheter between the or in the ventricular space within the brain, and this is going to be connected to the drainage system outside the body. And this will allow the system to drain continuously, or it could be intermittent, in order to control the intracranial pressure. It will relieve the pressure in the brain. And again, this is highly indicated for a patient with a TBI or hydrocephalus or subarachnoid hemorrhage as well. Or maybe if they have intracerebral bleed, then this is also an alternative to the treatment. Now, before the patient has the procedure, before we're going to send this patient to the procedure room, we're going to make sure that there's adequate imaging study that will determine the optimal placement site. And this is going to be done in sterile conditions. Make sure that this patient is, this is done in the OR setting, or it could be done in a designated place in the intensive care unit, wherein the neurosurgeon will be inserting the catheter through a small hole that is being drilled into the skull. And the catheter is going to be connected to the drainage system that will allow for monitoring and also the draining of the CSF. Now, this is really going to allow the nurses to check into the ICP and also make sure that we are adjusting the drainage according to the ICP readings as well. Because if there is too much drainage, this can also cause complication. While if there is very slow drainage, this will not be able to relieve the pressure inside the brain as well. Now, take note that this is an invasive procedure. Infection prevention is key. We want to make sure that we are preventing unnecessary, or we are going to monitor signs of infection in this patient. So the catheter should be checked from time to time to ensure that there is patency of the drainage and make sure that it's not obstructed. Now, guys, this is a tube inserted into the brain tissue. So there's going to be a possibility that they're going to have infection. They could possibly end up with bleeding, or a complication such as obstruction, or maybe if there is excessive drainage of the CSF as well. And again, regular monitoring of the EVD should be done in order to eliminate these possible complications. We got to assess the drainage. We need to exercise infection control. We want to make sure that our patient is positioned ultimately in order to promote drainage. And let's talk about another procedure here, which is actually part of our test today. This is what we call as the ventriculostomy. What is this? So this is another procedure, an invasive procedure that is going to involve the insertion of a catheter into the brain's ventricles to drain the excess fluids. And this will also relieve the ICP. Now, this is also indicated in the TBI, hydrocephalus. And again, imaging will be part of the pre-procedure checklist. We want to make sure that there is optimal placement of the catheter as well. This is a sterile procedure. So they're going to do this in the OR. It could be the designated spot in the ICU. So here, we are going to manage the ventriculostomy. We want to make sure that we are monitoring the ICP as well, and also making sure that the CSF drainage is not rapidly drained, or if there is slow drainage, then we're going to make sure that we have the patency of those tubing as well. Again, catheter function is important here. We want to make sure that our patient is positioned in order to prevent those possible complications. Now, take note, guys. We're going to have to talk about the nursing process here. So let's just breeze through before we're going to go to do our exercises. So in the nursing process, again, we'll start with the assessment. We're going to make sure we have that careful assessment in our patient, especially checking for the ICP increase. So again, our attention will be on the level of consciousness. If there is alteration in the level of consciousness, let's say confusion, drowsiness, then we have to take note of that. We're going to monitor if there's any progression. We have to check for their pupil responses as well. Before we go do that, do your diligent pupillary check. Remember about the anisocoria, if there's going to be involvement of the brainstem and optic nerve. There's going to be inequality, sluggishness in the pupillary response. Another thing is pupil response. What are the other things that we need to look for in this patient? Assessing their ICP. Well, we're going to take note about their LOC as well. What else? Nausea, vomiting. Persistent vomiting is a sign of increasing ICP. Another is the assessment, monitoring of our pulse pressure, wherein this is basically the difference between the systolic and diastolic blood pressure. So if your diastolic, your patient's diastolic blood pressure is greater than 60 or greater than 100 or 60 to 100, then this is now considered as widening of the pulse pressure. Another is to monitor our patient's heart rate, to take note of that bradycardia, slow heart rate, which is basically one of the key signs in the increasing ICP. Now, take note about the temperature as well. They will end up with hyperthermia. Blood pressure, systolic blood pressure will be increased. Heart rate will be somewhat lower, bradycardia. All right. So what else do we need to assess here? Patient's cardiac status should be closely monitored. We know that they're going to be prone to developing those cardiac dysrhythmias. Remember about the release of the catecholamines, that sympathetic storm. And so we are supposed to capture all those dysrhythmias and treat them accordingly and give them those meds as prescribed. Now, take note about the diabetes insipidus. Remember about the excessive diuresis because of the lack of antidiuretic hormone. So we are going to check and monitor the amount of fluids that they are losing, guys. And take note, they will be losing at least 6 liters to 10 liters per day. That's how excessive the diuresis is in diabetes insipidus. They're going to end up with the hypovolemia because of that. What else? Hyponatremia. If there is syndrome of inappropriate antidiuretic hormone, if there is massive reabsorption of the fluids, it can cause the, what do you call this? The dilutional hyponatremia, which can also lead to cerebral edema. Yeah. So again, we're going to have to manage that with correcting the sodium level. What else? Lab value monitoring. This is very important. We got to take a look into their coagulation studies, electrolyte counts, the red blood cells, white blood cells, ABGs. Take note that they are prone to developing the coagulopathies, abnormal bleeding. There's going to be imbalances in their sodium levels, either hypo or hypernatremia. The patient will probably end up with elevation of the white blood cell count, possibly because of those invasive procedures, or they might have anemia as a result to the IV fluid infusion as well, and hypoxemia. We are going to detect if the patient has any imbalance in their arterial blood gases as well. So those are the things that we need to pay attention in the assessment phase. What else? We're going to have to monitor the patient's neurological status, of course. Yeah, this is quite, we can do this simultaneously, right? So here, our patient will need the GCS monitoring, taking a look into their mental state as well, the level of consciousness, if there's any worsening. Now take note about the cardiac function. Again, I already did that. What about risk of injury? Why they are at risk for injury? Remember that they are going to have those electrolyte imbalances. They will have the potential to get confused. Their level of consciousness will be decreased. They will not be aware about their surroundings. Their cognitive function will be impaired this time. So they probably will be pulling those IVs, tubings, or maybe if there's a catheter, urinary catheter, they're going to be pulling those contraptions. So again, our care around this time will focus on preventing the different, or in preventing those injuries. Now, especially with the fall risk, right? That's a huge thing. So if the patient will have the cerebral edema as well, take note about that. The cerebral edema itself, ICP increase can also lead to the seizures. So our patient should be kept in the seizure precaution, also fall precaution. So please take note about those things that will be incorporated in preventing those injuries. All right, seizure precaution. This will involve the use of the side rail pads. We have to make sure that there is readily available oxygen, suction equipment. For fall risk, we're going to have to activate the bed alarm, make sure that our patient will be closely observed, maybe with the use of a sitter, frequent observations, dimming of the light because of increased stimuli. This can cause the seizure as well. So we want to make sure that we are controlling the amount of stimulation into our patient. All right, let's have the interventions this time. So what are those interventions that you should be doing? Well, airway is important. We need to maintain adequate cerebral perfusion. This is huge, as we know that if there is increasing pressure in the brain, it can also cut the blood supply to the brain tissue as well. So we want to make sure that the patient is getting enough oxygenation to the brain. We want to make sure that their airway is open. We have to regularly check if their airway is clear to facilitate breathing. What else? We're going to have to check for their ICP levels in order for us to manage the manifestations. Okay. Now take note about monitoring their oxygen levels as well, their blood pressure. Make sure that they are maintaining their blood pressure greater than 90. Make sure that their blood pressure is kept within that range, safe range. It could be greater than 90 mmHg or less than the cutoff. We're in, there's that 180. We don't want to maintain that blood pressure, hypertensive, or that increased systolic blood pressure. We don't want that as well, because that will decrease the perfusion to the brain tissue as well. Now, another is the monitoring of our patient's level of consciousness, the cranial nerve function, motor function, in order to capture those signs that may signify that there is now worsening of the brain injury, especially temperature as well. That's part of the care, checking the patient's response to the medications that we are giving them, the administration of the osmotrol or the mannitol to decrease the pressure inside the brain. Yes, don't forget about that. Mannitol, osmotrol, okay. And of course, we are going to track into the patient's laboratory data as well. We have to look into the lab values, especially the electrolyte imbalances, their ABGs, the blood cell counts, especially for those complications going on. We need to report them right away to the medical provider if there are any drastic changes. And we're going to have to deal with the hypernatremia. Gradual correction of the hypernatremia. What else? Managing the hyponatremia. We have to gradually correct that as well in order to prevent the ODS. And we have to monitor the patient for their coagulopathy, especially that they will end up with that DIC. So we will be monitoring the PTT as well. Now, part of the care here is to check the dressings, those drains, especially the surgical sites for any signs of infection, redness, swelling, those kind of things. So our patient is at risk to developing the infection. So take note of the color of the drainage as well. And the amount of drainage, if it is going to be too excessive, wherein there is a rapid reduction of the ICP, then that's something to be addressed as well. Now, what else? We are going to continue with our patients. Did I mention this already? Yeah, we're going to maintain the patient's respiratory function, make sure that we are assessing, monitoring their respiratory rate, their oxygen levels, their ABG values. We need to reposition them accordingly, preventing those extension, flexion of the neck, also flexion of the hip, excessive pressure into the tummy, because this can lead to increasing ICP as well. We want to make sure that our patient's airway is clear, make sure that their breathing is supported this time. What else? Nutrition. That is a huge thing as well. We want to make sure that this is resumed at least 3 to 5 days after we had stabilized our patient in order to meet those nutritional requirements. All right. Now, again, I've mentioned about this earlier regarding the placement of a nasogastric tube, or it could be the gastrostomy tube if the enteral nutrition is expected to last more than 1 to 2 weeks. And we need to monitor the patient for any diarrhea, especially with the tube feedings, in order to prevent those complications, special electrolyte complications. Now, let's talk about the prevention of the gastric ulcers. This is a huge thing, especially in a patient with a TBI. We're going to have to administer here those H2 receptor blockers, the famotidine, cimetidine, because of the stress ulcer, and also to prevent the GI bleeding. So this is our medication that would be commonly used in the treatment. Consultation with a dietitian. This is important. So we will know for sure what would be those elements that should be included in their feeding, right? Another thing that we should be taking care of will be the glucose monitoring, especially if there is a history of diabetes mellitus. We have to control their blood sugar as well to prevent those complications of hyper and hypoglycemia. Part of the care is to check their swallowing once they are waking up, and if they are going to probably resume oral feedings, then before that is initiated, this is going to be evaluated first by the speech therapist, or could be done with the testing, the dysphagia swallow testing under radiology. What else? Oh, that's it. So swallowing evaluation is important here, especially when they are starting to wake up. They are really prone to developing those aspiration pneumonia as well. Now let's go right ahead into our activity, our first question of the day. It states, a patient suspected with TBI is admitted with a blood pressure of 126/70, a pulse rate of 112 beats per minute, respiration of 24 breaths per minute. Which subsequent vital sign set taken an hour later would be the most concerning to the nurse? Is it A, blood pressure of 156/66, pulse of 56 or 54 rather, respirations of 12, B, blood pressure of 136/70, pulse of 92, respiration 30, letter C, blood pressure of 146/76, pulse rate of 110, respiration of 26, and D, BP of 112/72, heart rate of 122, and respiration of 28. Again, the question is about a patient that has a suspected TBI with an admission blood pressure reading of 126/70 and a pulse rate of 112 per minute, respiration of 24. So if we are anticipating a complication here, subsequent vital signs set taken an hour later, what would be the set of vitals that would concern you the most? Is it A, high blood pressure of 156/66, pulse rate 54, respiration that is 12? I'm seeing letter A's mostly, with letter D, blood pressure 112/72, 122, heart rate, respiration of 28. Remember about that Cushing triad. Guys, please do not forget that. Take note about the elevated systolic BP, widening pulse pressure, and also the irregular heart rate. Actually, widening pulse pressure is basically that one. Bradycardia is part of the Cushing, okay? I'm just including that. Again, please take note about the widening pulse pressure, irregular respirations, not HR, irregular RR, and bradycardia. So please identify those vital signs that will fit into the Cushing triad. There's nothing else but letter A, remember? Look into the widening of the blood pressure, 156/66. That is huge. What's the difference? That's about 90. That's greater than 60 mmHg. That is already a sign that the patient is going into systolic hypertension. And the patient's heart rate is already going lower, 54. And the patient's respiration is 12. Could be irregular. And when you're looking into the other values right here, blood pressure 136/70, you don't see a whole lot of widening between the systolic and the diastolic. The respiratory rate in letter B, or I mean the heart rate of 92, nothing remarkable about that one. The respirations of 30, it's not really clear. It's somewhat kind of vague. It's either irregular, right? But it's not stated, but it could be higher or lower. But it doesn't really support the Cushing triad. What about letter C, blood pressure of 146/76? What's the difference? 146/76. That is about 70. Not a whole lot of widening here compared to letter A. Let me clear my... So this is a possibility. The blood pressure is starting to widen, but not significant compared to the letter A. The heart rate is 110 beats per minute. It's tachycardic. We are going to remove that one. The respiration is elevated. We don't know if it's irregular. It's also vague. But again, the patient here will not really fit into the characteristic Cushing triad. The blood pressure of 112/72, not a whole lot of difference between the systolic blood pressure and the diastolic. The patient here is tachycardic. Remove that one. The patient's respiration is elevated, 28. But when you're going to compare here the different options, letter A would fit more into the Cushing triad, wherein there is widening of the pulse pressure. The patient's systolic blood pressure is elevated. The patient's heart rate is low, and the respiration is on the low side as well. Okay, so let's select our answer, which is letter A. Guys, don't forget about the Cushing triad in ICP increase. Okay. Now, let's have number 2. The nurse is monitoring a 58-year-old male patient who was admitted to the neurological unit after a car accident. The patient has a history of hypertension and diabetes mellitus. He was brought to the hospital with symptoms of confusion, headache, and nausea. Initial imaging showed a small subdural hematoma, and the patient's Glasgow Coma Scale score was 12 upon admission, and he is now at risk for increased ICP. Now, the question here is, actually, I omitted the question. The question here would be, which of the following options would signify increase ICP? Let me just type that in real quick. We are on page 1217. 1217. So you're going to select here the option that will signify increasing ICP. Wait. All right, so that's the entirety of the question. Is it one pupil larger than the other? Or is it B, dropping systolic blood pressure, C, fast heart rate, D, lowering body temperature? Which of the following signs and symptoms signify increasing ICP? Remember about that? Anisocoria? Yeah. The correct answer for this question is letter A. Again, if the injury is extensive, if there is increasing ICP, if it's probably pushing into the optic nerve and into the brainstem, your patient will end up with anisocoria. Letter A. All right, that is the correct answer. it is an indication that the patient here has increasing ICP. Now, the patient has inequality of the pupils because of possibility of the compression on the cranial nerve number 3. What is this? The oculomotor nerve. This is going to cause that inequality in the pupil size. Cranial nerve number 3, which is oculomotor. So it can lead to, as well, the shifting of the brain tissue into the other side. What else? We have dropping systolic blood pressure. Remember, guys, that our patient will instead have elevated SBP, not dropping. This is incorrect, right? Typically, the blood pressure here, especially the systolic blood pressure, is going to be increased because when there is an ICP increase, the body will try to compensate that by increasing the systolic blood pressure. Remember, guys, when the brain tissue ICP increase, remember about the O2 perfusion is impaired in the brain tissue, right? The perfusion is impaired whenever there is ICP increase. So the compensatory mechanism here by the body is to cause the elevation of the systolic blood pressure in order to attempt, this is an attempt by the body to maintain perfusion to the brain tissue. And that is why there is elevation of the blood pressure, okay? That's the initial compensatory mechanism. All right, in order to protect the brain, in order to maintain blood supply, but still it is going to be ineffective because of the increasing pressure. It will be continuous. So the patient will just end up with hypertension of the systolic, but it's not going to be an effective compensatory mechanism. Our patient will have bradycardia, not tachycardia, so we are eliminating that one. What else? Lowering body temperature. Remember that our patient will have elevation of temp instead of hypothermia, right? The hyperthermia is known in our patient with the increasing ICP because of the hypothalamic dysfunction. Alrighty, so please take note, guys. Our patient here in this scenario with an increasing ICP, they will have an unequal pupil size. Again, this is caused by the impairment on the oculomotor cranial nerve. The patient will end up with systolic hypertension. Their heart rate will go down, not faster. Their temperature will go up. Let's have number 3. A 35-year-old female patient is admitted to the ED following a motor vehicular accident. She has a significant laceration on her forehead and has been complaining of a severe headache and dizziness. During the assessment, the nurse observes clear fluid draining from the patient's nose. The patient has no known allergies and is currently conscious and oriented. I also omitted the question here. Now, the question is basically, what would be the nurse's action in response to the patient's drainage coming from the nose? All right. That is question number 3. The question is, what is the best nursing action? What is the nursing action? What is the priority nursing action? Okay. All righty. Will you do pinching of the nose? Will you allow tilting the head backward? Or are you going to provide the patient with tissues for the patient to use? Or will you give an antihistamine for potential allergies? Your patient has had the accident, right? There is significant laceration on her forehead and is complaining of severe headache and dizziness. Take note, guys, this is a case of a TBI, traumatic brain injury. Now, while you're doing your assessment, you're noticing clear drainage coming out from the patient's nose. The patient has no known allergies. Hello, Pushpa. Welcome. Right, CSF fluid. So what will you do here in this scenario? Will you pinch the nose? Or will you have the patient tilt the head backward? Or are you going to give them tissues? Or are you going to give them antihistamine? Let's eliminate letter D. What is in letter D? Will this help the patient? When you're going to give them an antihistamine for potential allergies, remember that the patient's medical history said no known allergies. You're going to eliminate that one right away according to the available data. And of course, when you are doing this step, antihistamine administration, this will not address the CSF leakage, right? It can delay the treatment. Will not address CSF leakage. And of course, the patient has no known drug allergy history. So it's not indicated. Okay? So our nursing action here basically is to take note what is really going on. We need to investigate what is this drainage. All right? So here we need to prioritize safety by confirming the drainage. What is this? And we need to also eliminate those options that can potentially worsen the patient's condition. All right, so we are eliminating letter D because of the patient's medical record. It is NKDA. Now, if we're going to answer letter A, pinch the nose closed. If you're going to pinch, or if you allow the patient to pinch their nose, it can also obstruct the drainage of the CSF. Can obstruct CSF drainage. And if you're going to do the pinching, it will eventually increase the ICP. Excuse me for a second. That tickle in my throat just came out of nowhere. All right. So pinching the nose will actually cause an increasing in intracranial pressure by not allowing the CSF to drain continuously. All right. If you're going to allow the patient to tilt the head backward, what do you think about that? If you're going to tilt the head backward, it will allow the fluid to drain down to their throat. You should not be doing that one. It will be difficult to collect the CSF for analysis if you are going to let them do that. Tilting the head backwards can cause the fluid to drain into the back of their throat. So you will not be able to collect the fluid for analysis. And your patient here will be prone to aspiration. We don't want that. Choking. No extension of the neck. Aspiration, choking. All right. No neck extension advised. If you are going to do letter C, that is the correct answer. Provide tissues for the patient to use. It is quite a hidden nursing action. The reason for that, it's because we want to identify what the fluid is. We need to get that sample to test for glucose. Okay? We're going to do that to test the CSF, to test fluid for glucose. And we know that CSF is rich in glucose. So that is the reason why we're going to give them to tissues. Never attempt to stop the drainage. Never occlude. It could be the ear that may have the drainage. Do not apply pressure to the nose. Do not apply pressure into the ear if it's draining clear liquid fluid. Again, this is CSF. If you're going to attempt applying the pressure, this will increase the ICP. So never do that. Okay. Let's have number 4. A 45-year-old male patient is admitted to the intensive care unit after suffering a traumatic brain injury from a fall. He is currently intubated and being closely monitored for signs of increased ICP. During the nurse's assessment, changes in the patient's respiratory pattern are observed. Now, the question is, what are those signs? What is a sign? Which of the following is a sign of increasing ICP? I did not do that. I did not include the question right away. I did that on purpose. We are on question number 4. Let me look for that page. Which of the following are manifestations of increasing ICP? Okay, please take note of that one. That is our question this time. All right. Which of the following manifestations are signs and symptoms of increasing ICP? Is it A, slow and irregular breathing? Is it B, rapid and shallow breathing? Is it C, uneven chest movement? Or D, nasal flaring? Remember about the Cushing triad? It could be more of the irregular but slow breathing, the bradypnea. Now, take note about letter A right here, slow and irregular breathing. This actually is a sign of the Cheyne-Stokes respiration. There is increasing ICP here. This is causing pressure into the medulla oblongata. Cheyne-Stokes respirations. And this is going to signify that there is compression involvement with the medulla oblongata, which control the respiratory rhythms. All right, so that is why they're going to have irregular breathing. Now, if you're answering letter B, rapid and shallow breathing, it doesn't fit into the Cushing triad respiratory pattern. Rapid and shallow breathing is not associated with increasing ICP. Rapid and shallow breathing is associated with respiratory distress. Okay, respiratory distress. What about an even chest movement? Paradoxical, or let's say asymmetrical chest movement. What do you think about the uneven chest movement? This could be related to rib fractures, right? Or pneumothorax. Yeah. This indicates rib fracture, pneumothorax. And it's not going to be specific to the increasing ICP as well, right? Let's take that down. What about nasal flaring? Nasal flaring. This is only observed, guys, when there is an increasing need to exert more effort, especially in respiratory distress. So this is a sign in respiratory distress commonly seen in patients with asthma, bronchiolitis. Or it could be pneumonia as well, right? Respiratory infections, such as pneumonia, or let's have ARDS, the acute respiratory distress syndrome. Our patient has indeed had the difficulty of breathing. But again, this is not a sign of increasing ICP. This is more of respiratory conditions, okay? Not about ICP. So we have our correct answer here, which is letter A, slow and irregular breathing. And again, take note about the Cushing triad. You got to remember about the pattern in the respiratory rate, especially. Okay. Now let's have number 5 this time. A 38-year-old male patient is admitted to the neurocritical care unit following a severe traumatic brain injury sustained in a car accident. The patient is currently intubated and on mechanical ventilation. To closely monitor and manage his intracranial pressure, a ventriculostomy has been placed. The patient's family is present and concerned, seeking to understand the purpose of this procedure. What would be the nurse's best response? Is it A, this system is managed by specialized healthcare staff? Is it B, it helps assess the brain's blood flow adequacy? Or is it C, it checks for changes in the cerebral perfusion pressure? Or is it D, it has multiple uses, including CSF drainage? What would be your best response to the family inquiring about the ventriculostomy? What would be your statement? Well, I'm going to start answering this time. If you had answered letter A, which is the system is managed by specialized healthcare team staff, we know that it is managed, right, by the healthcare team. But the statement itself is not clarifying the purpose. So you're trying to evade the actual question the family is trying to know, right? Or if they're trying to understand really the purpose. So this response is not addressing their query about the device. So we are going to eliminate that one. What about letter C? It checks for changes in cerebral perfusion pressure. Do you think that is appropriate to tell the family members? It checks for changes in cerebral perfusion pressure. So technical. They will not be able to understand the technicalities for this device. This statement, though, is correct, but it is going to be too complex for them to understand. They are not familiar with the device and also the terminology. So we are going to look for that statement that is going to be more understandable and make sure that your statement is concise. You don't have to describe way too many things initially. So we are going to mark this as a wrong option. It checks for changes too technical. Okay. What about letter D? It has multiple uses, including CSF drainage. But will this address their question about the purpose of the ventriculostomy? And when you're telling them it has multiple uses, including CSF drainage, we know that it can be used in so many ways, right? It can drain the CSF. It can also allow us to monitor the ICP. But if you are giving way too many information initially, this could somehow give them too many things to think about. It will lead to confusion. It can overwhelm them. All right? Too many things going on here. It has multiple uses, including CSF drainage. Too overwhelming for the family, right? Make your statement as simple as you can. So, the initial statement here would be to give them a very concise reply. And you're going to tell them the actual purpose. Concise reply. And you'll just tell them the purpose. And that's no other than letter B. It helps assess the brain's blood flow adequacy. Remember, we are monitoring the patient's intracranial pressure, right? And then the remainder for that would be, the other reasons would be to allow drainage of the CSF if there's to excess cerebrospinal fluid. But again, this question will check you on how you're going to respond to a query from a family member or family members that are not medical professionals. They don't have any clue the medical jargon. You gotta have to simplify your response to them and do not overwhelm them with so many information all at once. So our correct answer here will be letter B. Okay. Now let's have number 6. A 45-year-old male patient has suffered a traumatic brain injury and is currently in the intensive care unit following a craniotomy. The nurse is tasked with maintaining normal intracranial pressure. Which action should the nurse prioritize? Select all that apply. Your patient is a TBI admitted in the ICU and has to be checked on their ICP. So which of those actions that you should implement in this patient? Select all that apply. Will that be encouraging coughing to clear secretions? B, raise the head of the bed between 15 to 30 degrees. C, inform the provider if ICP exceeds 20 mmHg. Or D, regularly check neurological status using GCS. E, engage the patient in active range of motion exercises. Which would be those nursing actions that you should prioritize? I'm seeing B, C, D. Raise the head of the bed between 15 to 30. Inform the provider if ICP exceeds 20. Regularly check the neuro status using the GCS. Yeah, those are the correct answers. Well done. Okay. B, C, and D. Why? Why not letter A? Encourage coughing and clear secretions. Remember, guys, if you are going to encourage them to do the coughing, and if you are going to do this, or if they're going to do this, rather, this will increase their ICP because of the increasing intrathoracic pressure, right? This will elevate the intrathoracic pressure. Okay. Yeah. Actually, when they do that, there's also an accompanying Valsalva maneuver. So this will also elevate the ICP, right? So this should not be encouraged. They should not be allowed to cough because, again, this will stimulate this will cause the intrathoracic pressure to build up. And also there is an accompanying Valsalva maneuver. This will elevate the ICP as well. Now, if you answered letter E, engage the patient in active range of motion of exercises, that would not be ideal because increasing their activity this time can increase the metabolic demands. Can increase the metabolic demands and will also increase the ICP, especially during the post-op phase. So you got to be careful when you are instructing this patient about the exercises. You got to be careful. All right. If you are worried about the physical activity, if you are really thinking about resuming the physical activity, this should be carefully managed, and you should minimize excessive exertion up until the patient condition stabilizes. Okay. Again, I know that you would be proactive, right? Minimizing those DVT and stuff, but you gotta weigh in the risk and the benefits. You gotta make sure that the patient is more stable before you're gonna engage them into those range of motion exercises. Okay. Why letter B? Raise the head of the bed between 15 and 30 degrees. We know that with head elevation alone, it can reduce the pressure inside the brain by enhancing venous return from, or it will decrease the venous return coming from the brain. All right. It will decrease the ICP. It will promote the drainage of the CSF, and it will prevent the ICP increase. If you had answered letter C, inform the provider. Of course, greater than 20 indicates that the patient has increasing ICP. This is concerning, and so we need to prevent that as well. Make sure that we are letting them know that the patient has elevated ICP. Now, regularly check neurostatus using Glasgow Coma Scale. This is a tool that will give us a better idea if there is worsening of our patient's neurostatus. Let's have number 7. A 34-year-old male patient is recovering in the ICU following a severe traumatic brain injury. He is being closely monitored for elevated ICP. Which factors are essential to monitor this patient? Select all that apply. Is it systolic blood pressure? B, urine output? C, breath sounds? D, cerebral perfusion pressure? Or letter E, level of pain? So which factors are essential for you to monitor this patient in order to check them for ICP increase? So what are those factors? Is it A, B, C, D? Mm-hmm. 5 to 15. So which of these factors that you should pay attention closely when you are monitoring the patient's ICP? Mary answered A, C, D, E, systolic blood pressure, breath sounds, cerebral perfusion pressure, level of pain. Victoria answered C. That's CP? CPP. May answered A, B, D, and A, B, C, D from Nirmala. Let's take a look into the systolic blood pressure. Systolic blood pressure. What do you think about the systolic blood pressure here? Yes, that's one of the answers that we should have. We have to check into the patient's systolic blood pressure because it will help us in calculating the mean arterial pressure, right? Do you remember about the MAP? Do you remember about the MAP formula wherein you're going to have the systolic BP value And then we're going to have to add that to the diastolic blood pressure, DBP. Hang on a sec, let me correct that. DBP, which is going to be multiplied by 2, and then you're going to divide it by 3. So the systolic blood pressure is important in determining the MAP, because the MAP is actually part in the calculation of what we call as the cerebral perfusion pressure, and we will be talking about this one. Cerebral perfusion pressure. All right. So that's why A is part of those factors. Okay. Systolic blood pressure. We need to make sure that there is appropriate blood pressure in order for us to maintain appropriate or adequate blood flow to the brain, especially in a patient with ICP increase. Okay. Now let's have letter B. Urine output. Will urine output be part of the monitoring, or is that part of the factors? We know that checking the patient's urinary output hourly is huge, right? It is an important parameter for assessing the overall fluid balance or the renal function, but it will not give us a clue or direct information about the ICP. So this is unrelated. This is going to I used map for questions 1, but not working. How come? What about letter C, breath sounds? Will the breath sounds be a factor in determining the ICP levels? We know that it is important that we are going to listen. We're going to auscultate the patient's lung sounds to check for respiratory function, right? To capture those adventitious sounds. To capture complications like pneumonia. But here in this scenario, we are going to give them that information or that factor that can be easily associated with the ICP levels. So breath sounds will not be part of it. Okay? Now, letter D. What is in letter D? Cerebral perfusion pressure. What is this? This is going to be calculated as the difference between the mean arterial pressure. So the formula here is going to be like this. The mean arterial pressure, and this is going to be subtracted by the intracranial pressure value. Okay, so that will be our formula for the CPP. CPP is the cerebral perfusion pressure. This is going to be the indication. This is going to be the range value that will tell us that the patient is absolutely getting enough blood flow to the brain while we are trying to manage the increasing ICP. All right, so the question here is from Nirmala. Please explain about MAP. Okay. The reason that I included the MAP here, because MAP is part of our formula. So before we're going to calculate the CPP, we need to get the formula first for the MAP. So basically the MAP is the pressure that will be required for the body to perfuse body organs. Okay, this will give us a better idea if the body tissues, organs, the brain, liver, systems, if they are able to receive adequate oxygen, blood supply, nutrients. Now guys, when I mentioned about the MAP in the past, remember that MAP that is greater than 70 mmHg is the acceptable value. Okay, remember about this? The MAP should be greater than 70 mmHg, especially when we are worried about tissue perfusion. Okay, when your patient has less than 60 mmHg, This is where you're going to be worried about impairment, decreased blood supply to the tissues. Okay? So, again, if the value is less than or equal to 60, this is going to signify that our body is no longer able to provide oxygenated blood, or oxygenated blood. So, again, the acceptable range should be greater or equal to 70. Now, how is the MAP obtained? Well, the formula is going to be this one. You're going to add the diastolic blood pressure that has been multiplied by 2. Okay, so your formula here is systolic blood pressure. You're going to add that by the diastolic blood pressure that has been multiplied by 2. Okay, and then you're going to divide it by 3. So for example, if your patient has a systolic blood pressure of, let's say, 100. Let me get rid of this off here. Eraser. Now my mouse is stuck. I can't even do anything. Oh boy. Hang tight with me. My system is frozen. Okay, here we go. So let me have my eraser. Yeah, it's kind of like getting busy right now. Whoops. Eraser. Here we go. No, I'm not talking about this one. Let me go back to that one. No, I'm lost. Where was that? Ooh. Is this the one that we are answering? MAP? Intrathoracic pressure? No, that's not the one. Increasing systolic. Yeah, okay. This is the item that we are talking about. Question number 7. Okay, we were talking about the MAP, right? Let me just make sure this is the correct question. Yeah, number 7. So like I've said earlier, the MAP should be obtained first before we can get that CPP value, which is the cerebral perfusion pressure. So again, we have our formula, which is basically MAP, which is the sum of the systolic blood pressure and the diastolic pressure that was multiplied by 2. DBP, you're going to divide it by 3, which is the constant. So for example, if your patient has a systolic blood pressure of maybe 160, hypertensive, right, in an ICP, systolic blood pressure. And for example, if their diastolic blood pressure is, let's put 50 this time. That is quite low. And then you're going to multiply it by 2. So what would be that? Okay. So you have 160 plus 100, right? And you're going to divide it by 3. So what is your value this time? Are you calculating? So that is a 260 over 3, right? $260 over 3. So, okay, my pen is getting wonky this time. I don't know what's going on, but I can't just type in. Okay, here we go. So that is 260 by 3. So your MAP value this time this is not helpful. My computer is freezing up. So that would be 260 by 3. So your MAP value is 86.6. 86.6. Now, this value, 86.6, will be used in our formula, which is the CPP, right? CPP is the difference between the MAP by the ICP value, right? 86 or 87. Yes, that's correct. So if we are going to calculate the CPP value, so this is going to be 87. And just for example, we are going to, what do you call this? Let's just assume that the ICP is elevated. Let's put 30. So what would be the CPP value here? What do you think? What would be your answer for the CPB? So your difference would be what? So that is about like 50, hang on a sec. 87 minus 30. So that is 57, right? Now, if we are going to look back into the CPP, cerebral perfusion pressure, take note, guys, that the target CPP, the cerebral perfusion pressure, should be somewhere between 60 to 70 mmHg, especially in a patient with traumatic brain injury. Again, 60 to 70. And our patient's value is only 57. The normal range should be 60 to 70. So our blood supply to the brain tissue is quite low. It signifies that the patient with ICP increase this time is actually not getting enough oxygen in their brain. That is why we have to get through the calculation first about the patient's MAP. Okay, so the patient, again, in this scenario that I'm just kind of putting all together with the value, I wasn't even ready for this calculation, but 57 is below the range of the acceptable range of 60 over 70. Again, the brain is not getting enough oxygenation. There is no adequate perfusion. All right, so back to the question here. He is being closely monitored for elevated ICP. Which factors are essential to monitor this patient? Select all that apply. So again, let's go back to the concept in calculating the MAP CPP. We need the systolic blood pressure. We need the cerebral perfusion pressure. And what else? Do you think that there's something else that we should be considering in this, or factors that we should be considering? Are there anything else that we need to include? I guess not, just the two, right? So our correct answers for this question are only letter A and letter D. The patient's level of pain. Yes, I know. If the patient's pain level is not controlled, we know that it can increase the ICP. But as far as the calculation of the, what do you call this? The calculation of the CPP, this is going to require the cerebral perfusion pressure and the systolic pressure. You're correct. You have a point there, Mariama, regarding about the pain management. If it's not controlled, it can lead to the increasing ICP. But if we are monitoring, if you're just asked about monitoring the patient's value, then our answers here are only about the systolic blood pressure and the perfusion pressure. These are the needed numbers that we should be paying attention, so we can get that idea that, hey, my patient is not getting enough perfusion this time. Okay, so this is basically asking for the value. Okay, all right, not really the physical conditions, but the value of the manifestations the other manifestations. So that's the answer, A and D. Let's have number 8. For a 28-year-old female patient with an ICP increased reading of 20 mmHg after a traumatic brain injury, which nursing intervention is most appropriate? Is it A, use a warming blanket, B, give low dose barbiturate? Correct answer. Yes, correct answers are D. Okay, so what are you going to do here? Are you going to provide warming blanket? Are you going to give low dose barbiturates? Or will you encourage deep breathing and hyperventilation? Or will you limit fluid intake? Your patient's reading is 20 ICP. So which nursing actions you should be providing for this patient? Appropriate nursing actions. Hang on a second here. 20. Okay. All right. What is your answer? 8 answer is letter D. Limit fluid intake for number 8. Limit fluid intake. What is your rationale, guy? What is your reason why you're selecting letter D? Limit fluid intake. Take note about the ICP of 20. We know that limiting the fluid intake really is going to be, or managing the fluid intake is important, right? But the fluid restriction or limitation of the intake will not address the immediate need of the elevated ICP. It will not. Okay? Other interventions that can decrease the ICP in our patients are the following. What are those interventions? Nursing actions, independent. Positioning, right, is one. Positioning the patient about 30, 40 degrees angle. It will reduce the ICP. What else? We are going to encourage the patient to do the deep breathing and hyperventilation. That is the correct answer. Why? When they are doing the deep breathing and hyperventilation, this can actually reduce the intracranial pressure. It will reduce that by the process of what? Do you know why the hyperventilation can reduce the ICP? Do you remember about the role of the CO2 and O2 in causing the vasodilation? Do you remember the rationale? Guys, when you are promoting the hyperventilation and deep breathing in this patient, this can reduce the carbon dioxide. Reduces CO2 levels in the blood. Okay? Which actually can lead into the cerebral vasoconstriction. Okay? There is that vasoconstrictive effect which will be beneficial in decreasing the ICP. Can decrease the ICP. That is the reason why having them take deep breaths, having them do the hyperventilation, not too excessively, but it has that benefit to reduce the CO2 concentration in the blood. When this happens, this can lead to the constriction of the blood vessels in the brain to some degree, right? Now, when there is vasoconstriction, this can now decrease the intracranial pressure. So this is directed in managing the elevation of the ICP in this patient. If you're answering letter D, again, this is not going to address the immediate need to reduce the increasing ICP. It will not. Okay, it might support, but it will not immediately cause changes into the ICP. All right. What about letter A? Use a warming blanket. Are you supposed to do that warming blanket for this patient? Remember that our patient's temperature is somewhat kind of elevated already. When you are providing a warm blanket to our patient, this can also increase the metabolic demands. Can increase metabolic demands. Rather, what we should be doing here is actually application of a cooling blanket. And this is much more appropriate rather than the warming blanket. As we know that the warm blanket can increase the metabolic demands and will potentially worsen the ICP as well. So we are eliminating that one. What about letter B? Give low dose barbiturates. Will this be a pharmacologic treatment for ICP? No. This is not known to be therapeutic, especially in managing early management of ICP increase. No. So we are going to eliminate that one. This is a distractor. Okay. So our correct answer here is only letter C. Encourage deep breathing and hyperventilation because of its effect in decreasing the CO2 content in the bloodstream, which will eventually cause vasoconstriction in the blood vessels in the brain, which will decrease the patient's intracranial pressure. All right, let's have number 9. The nurse should alert the healthcare provider if a patient with increased ICP shows which change. The nurse should alert the healthcare provider if a patient with increased ICP shows which change. Is it A, widening of pulse pressure, B, slower pulse rate, C, enlarged non-reactive pupils, D, lowered consciousness level? The nurse should alert the healthcare provider if a patient with increased ICP shows which change. You'll see here that there are so many signs of ICP, right? There are many of those. Actually, yeah. Is it widening of the pulse pressure? Is it slower pulse rate? Is it enlarged non-reactive pupils? Or will that be letter D, lowered consciousness level? So I really want you to think about the early signs of increasing ICP. That is your clue. What is your clue here? That's the level of consciousness. Right. The correct answer for this is letter D. I know, this is also a sign of ICP increase. This one as well. Non-reactive pupils, not both. There will be anisocoria, right? But we are going to identify the early sign of increasing ICP. That is your task here. That is what we have in letter D. Decreased level of consciousness. Take note of that. That is the earliest sign in neurological deterioration because of the increasing ICP. If you had answered letter A, widening of the pulse pressure, this is a later sign. All right. What about slow pulse rate? Another later sign. Remember about the Cushing triad? Yeah. And letter C, enlarged non-reactive pupils. This is indicating that the patient already has severe injury to the brain. Severe brain injury. Non-reactive pupils, no longer anisocoria. Remember I mentioned about anisocoria and equal pupils, but here, non-reactive, both pupils. This is signifying severe brain injury and also herniation. This is pretty bad, guys. Herniation of the brain is kind of like, hey, I think you're gonna pass away in the next few hours, right? So again, I need you to make sure you know the earliest signs of ICP increase and also the late signs. So these three, A, B, C, are late signs of ICP increase. Now take note. Okay. So what do you think, guys, are the early signs aside from the decreasing level of consciousness? What are the other early signs? Let me just make a list. Other early signs. We have the headache, HA. There's also the nausea and the vomiting. So those are the early signs. If your patient is in the later stage, late signs, this will include those three. The widening. Yeah, restlessness or listlessness. Yeah, that's part of it, especially. Okay. The late signs. What are those late signs in ICP? Widening pulse pressure. Widened PP. What else? Irregular respirations. All right. So basically here, the patient will have a much more elevated amount of pressure inside the brain because of the what do you call this? Increasing pressure. There's probably increasing edema in the brain as well. So what else? Widened pulse pressure, irregular respiration, systolic BP, elevation. Yeah. So just those. I'm not going to overwhelm you with so many manifestation. HA is headache. I'm sorry. That's headache. Trying to shorten. Headache. That's headache. HA. Okay. So let's go back into our early manifestations. Those are the ABC are the late stage. Sorry. ABCs are late stage signs of increasing ICP, whereas letter D, lowered consciousness level, is part of the early signs, including headache, nausea, vomiting, and restlessness. Okay. Let's move forward to number 10. For a patient with an ICP of 20, which position should the nurse anticipate implementing for this patient? Is it A, elevate the head of the bed 30 to 45 degrees, B, place in Trendelenburg position, C, position on the left side, and D, elevate the head with 2 pillows? What do you think, guys? For a patient with an ICP of 20, which position should the nurse anticipate implementing for this patient? Elevate the head of the bed 30 to 45 degrees. B, place in Trendelenburgs. C, position on the left side. D, elevate the head with 2 pillows. The headache is in the severity, AGI. The headache that is in the late stage is much more severe. Yeah, that's the difference. I did not specify that one. But the headache that will be experienced in the later stage will be much more severe. Okay. Please add that in your notes. So what would be your intervention this time for a patient that has increased ICP of 20? Are you going to do letter D? If you picked letter D, elevate the head with 2 pillows. Remember when you are putting 2 pillows to support the neck, this can cause neck flexion. You don't want that, guys. Neck flexion should be avoided. Do not do 2 pillows. That is too much for this patient. This can cause elevation of the ICP. Aside from the flexion is the extension. Another head or neck placement that you should be avoiding. Either extension or flexion of the neck can cause elevation of the ICP. So please do not do that. Hyperflexion or hyperextension. Okay, your patient should at least have that neutral placement of the neck. So 2 pillows already is going to cause hyperextension. You should avoid that. What about position on the left side? Positioning on the left side will lead to extension and flexion. Hyper, X, and also hyperflexion. We are eliminating that one. What about letter B? Place in Trendelenburg position. Another position that you should avoid, right? This can elevate the patient's ICP as well. Never put them in Trendelenburg position. Should not be placed in this position. Your answer should be letter A. Elevate the head of the bed 30 to 45 degrees angle. This will facilitate drainage, venous drainage, and it will also reduce the increasing ICP. Okay? That's letter A. Let's have number 11. A 34-year-old male patient with a severe traumatic brain injury has been administered mannitol, osmetrol to manage elevated ICP. After giving mannitol, which factor should the nurse watch closely? Is it A, muscle relaxation, B, fluid balance, C, increasing pulse pressure, D, enlarging pupils? So which of those would be watched closely by the nurse after or giving the mannitol? Yes, after the administration of the osmetrol. So which of those should be monitored for this patient? Okay, you really need to identify the drug, what that is. And osmetrol is an osmotic diuretic. This can promote the excretion of excess fluids from the brain, right? It is an osmotic diuretic. It is high-powered diuretic. It can lead to fluid deficit. So what you should watch for here is fluid balance. You need to do accurate intake and output measurement, okay? Since the medication is an osmotic diuretic, it will draw the fluid coming from the brain into the extracellular spaces and into the bloodstream. So your patient will have increased urinary output. And aside from that urinary output measurement, you need to make sure that the patient is hydrated in order to prevent the electrolyte and fluid imbalances. Okay, please take note. Monitor for signs and symptoms of dehydration. Fluid electrolyte imbalance. Please take note of that. All right. You have to monitor signs and symptoms of dehydration and fluid electrolyte imbalance, especially with a potassium. That's a key cation that you should be paying attention. Fluid balance is the answer. If you had answered letter D, enlarging pupils, why would you answer letter D, enlarging pupils? Will that really correlate directly to the administration of the osmetrol. We know that the ICP is going to be managed, right, by the mannitol. But the dilation actually is going to cause the decrease in the fluid in the brain. So what do you think? Will there be enlarging pupils? I don't think so. If the medication is working, the pupils should not be enlarged or dilated. But this is actually a sign of worsening ICP. So this is not our answer. Worsening ICP. So this is not our indicator. Our nursing task here is to check and balance the patient's intake and output. We need to monitor the patient's hydration status. Letter C, increasing pulse pressure. What is that? Increasing pulse pressure, would that be beneficial to our administration of osmetrol? Will that be our goal? We know that pulse pressure measurement is also important, but it is not the primary effect in the reduction of intracranial pressure as well. So if you're talking about increasing pulse pressure, that's basically similar to the widening pulse pressure. So it's not telling us that the patient is responding to the treatment. So you're going to eliminate that as well. Okay. And muscle relaxation. The muscle relaxation is not an indicator that our treatment is effective this time. It does not induce muscle relaxation. So it will not contribute. It will not have any association at all. So we're going to have to eliminate. Letter A. Question. Yeah, watch out for signs of diabetes insipidus, fluid volume deficit. Question number 10. I thought head of bed should be. Let's take a look into number 10. You can have the placement of the head of bed either 15 to 30 degrees or could be over 30 to 45 degrees. It depends, AGI, as long as the head of bed is elevated and you're maintaining the alignment, the neutrality of the patient's neck. As long as there is no compromise in the patient's neck placement, then that is totally fine. 15 to 30, 35, 30 to 45, it doesn't really have much difference, okay? So for example, if your patient probably would be taking, if they're allowed to take anything by mouth, if they are still able to, of course, there's going to be some exceptions, right? But here in the scenario number 10, nurse anticipate implementing for this patient, like I've said earlier, the 15 to 30 would be a different level as well. There's not really a strict range of the elevation as to control of the ICP. There's none. There's nothing established. Okay, as long as the head of bed is elevated and we are maintaining the placement of the neck, and also there's no hyperextension or extension or hyperflexion. All right, I hope that clarifies your question. Let's have number 12. A 27-year-old female patient with a severe injury displays internal rotation, adduction, flexion of the arms when pressure is applied to the nail beds. How should the nurse record this observation? Is it A, withdrawal from pain, B, pain localization, C, decorticate posturing, D, decerebrate posturing? So your patient has displayed internal rotation, adduction, flexion of the arms when pressure is applied to the nail beds. You're doing the Glasgow Coma scale in this assessment. So how should the nurse record this observation? Will that be A, B, C, or D? All right, well, I'm waiting for your responses. I'm going to start answering this time. If you answered letter A, withdrawal from pain, will that fit into the description? Internal rotation, adduction, flexion of the arms. Letter A, withdrawal from pain. That is incorrect, because when you are seeing this in a patient, withdrawal from pain, they're going to have that purposeful movement where they're going to pull away from a very painful stimuli. So this is an attempt to escape the source of the pain. This is purposeful withdrawal. And take note that the patient already has adduction and also flexion of the arms. Those are your clues. Okay? Adduction, flexion. What would be that? Adduction, flexion? Is it decerebrate? Uh-oh. Okay. So let's have letter B this time. What do you think about letter B? Pain localization. We know that pain localization simply means that the patient here is having a deliberate effort to move toward or away from the site of pain. So this is also a type of purposeful action that will indicate higher brain function. So pain localization signify higher brain function. You're not seeing a deteriorating condition yet in letter B. So we are eliminating letter B as well. Now we are having the C and the D. Let's have letter D. Decerebrate posturing. Remember that decerebrate posturing is the extension, right? There is going to be extension of the arms and legs. Do not forget this. This is basic, especially in the Glasgow Coma scale. This is basically signifying that there is now severe brainstem damage. Severe brainstem damage. So your patient really has a profound brain injury this time. It is more serious than the decorticate posturing. So the correct answer here is letter C, decorticate posturing. The patient now has that, what is that? Flexion. That is the word right there. Flexion of the arms. That was the clue, guys. Flexion of the arms. So this is basically a condition wherein your patient has a damage to the corticospinal pathways. Okay? Damage to the corticospinal pathways. Another indication that there is severe injury, but not as bad compared to the decerebrate posturing. Okay? Decerebrate is worse than the decortication. When you have the decerebration, there is already brainstem, severe brainstem impairment. Okay? Don't forget that. This is part of your GCS. Okay, before I'm going to continue number 13, again, I'm inviting you to enroll to our NCLEX course at www.stancoastnclexcoaching.com and take a look into the description box for that link in order that you can check out our website. And just letting you know that we have upgraded our number of hours on the on-demand videos plus the animated video series. And we have the 3,000 NCLEX questions on top of the 200 NG test questions. So kindly do that. And don't forget to hit the like and subscribe button. So we will be able to do some more of these free live sessions. And I'm hoping that we can still do that. All right, let's have number 13. Yeah, the clue. Let's have number 13. What should the nurse monitor to evaluate the effectiveness of IV mannitol in an unconscious patient? Is it A, blood pressure? Is it B, oxygen levels? Is it C, intracranial pressure? Or is it D, blood cell counts? What should the nurse monitor to evaluate the effectiveness of IV mannitol in an unconscious patient? Is it blood pressure? Is it O2? Is it intracranial pressure? Or D, blood cell counts? Of course, that's easy. Easy to spot. It's a given. That is the correct answer. And again, how are we going to determine the intracranial pressure? Remember about the ventriculostomy, right? ICP monitoring. And of course, you're going to have to also observe the patient for those manifestations, right? So if you answered letter A, blood pressure, will that be a direct indicator that there is improvement after you delivered the mannitol? We know that the mannitol itself can also affect the blood pressure, but it is not the primary indicator of the effectiveness. We are being asked about the effectiveness, the therapeutic effect. Please take note of that. Is it effective for the patient? Is it doing what it's intended to do? Okay, so this is basically what the question is. So we are going to look for this intracranial pressure. The blood pressure will be somehow be affected, but will not be the primary indicator. Same thing with the oxygen levels. It does not directly affect oxygen saturation, and the same thing with the blood cell counts. Yes, the MAP and the CPP. You're correct there, Chang. Thank you. All right. Very good. Let's have number 14. A 32-year-old male patient has sustained a TBI in a recent car accident. Upon exam, the patient responds to verbal cues by swearing inappropriately when stimulated and attempts to push away a painful stimulus but does not follow verbal commands. He opens his eyes to verbal stimuli but does not respond in a fully purposeful manner. What is the Glasgow Coma Scale score? What would be the GCS in this patient? Okay, the patient is swearing inappropriately. Patient responds to verbal cues. Yes, he can respond to verbal cues with swearing. Well, that's wonderful. And he tends to push away from a painful stimulus, but does not follow verbal commands. And we have opens his eyes to verbal stimuli, but does not respond in a fully purposeful manner. Oh boy. Okay. Let's eliminate things here. Letter D. Letter D is a perfect score. No. Our patient's GCS score this time is, this is way too perfect for this scenario. We're going to eliminate that one. When you have a perfect score of 15, that's basically perfect score of the eye opening, which is 4, the verbal response, which is 5 total, and the motor response is 6, 4, 5, 6. But our patient does not have all those assessment findings, so we are eliminating that one. If you had answered letter C, number 13, or 13 Glasgow Coma Scale, what do you think? 13 is gonna tell us that they are opening their eyes, they have better verbal response, which would involve following commands. But take note, guys, does not follow commands, verbal commands. Initially, take note, the initial assessment that the nurse got was patient responds to verbal cues by swearing inappropriately. That's verbal response, okay? Opens his eyes to verbal stimuli but does not respond in a fully purposeful manner. So if you're answering letter C, 13, the patient here should indicate better opening, right? Eye opening, and they will have better responses as to verbal. And they would have to follow those verbal commands. And they will be more appropriate when they're responding, right? If you're asking them the question, they will answer appropriately. But look into the statement right here. Swearing inappropriately. That is a clue for you. So 13 will not be the value. That is way too high for this patient. What about letter A? 9 Glasgow Coma Scale. Is 9 appropriate, or is that the correct calculation? Well, a GCS of 9 would signify that they are not really opening their eyes, right? Lower eye opening, their responses verbally is actually very poor. And also with the motor responses, which do not align at all with the behaviors that we are reading right now. Okay, so our correct answer here is 11. That is letter B. Why 11? Well, the patient actually scored 3 for the eye opening. Okay, the eye opening is scored 3, and the verbal stimuli or the verbal response is actually going to score about a 3 as well. They have that inappropriate response in their words. They are swearing. Now, if you are going to check into the motor response, they are localizing pain. Take note of the patient's response. Attempts to push away a painful stimulus but does not follow verbal commands. So that is going to be scored as a 5. So take note, our correct answer here will be letter B. This is a total of score 11. Eye opening of 3, verbal response of 3, motor of 5. Okay, please remember that one. Again, our patient is opening his eyes only with verbal stimuli. Okay, they're only doing that whenever you are talking to them. That is a 3. The perfect score is what? 4, right? Perfect score is 4. For the verbal commands, the perfect score here would be 5. For the motor, the perfect score is 6. So basically, our patient's eye opening is not going to be given a score of 4, which is the topmost. I mean, your patient can open their eyes spontaneously, but they're not opening it spontaneously. They need to have that sound when you are talking to them, then they're going to open their eyes. If you're going to elicit verbal response, if, let's say, for example, you're talking to them, well, but they're responding by swearing. They're not oriented, especially when you're going to ask about, can you tell me the date today? Or when is your birthday? The perfect score for that should be today is Friday, according to the what do you call this? The correct day. If they are responding the correct day, the month, then they're going to be given a score of 5. However, if they're going to be answering wrongly the date, if they're going to tell you I'm in the clinic instead of answering I'm in the hospital, that is already considered disorientation. So that would be scored as a 4. But for this patient that is responding inappropriately, incoherence, swearing, that is scored as a 3. Okay. Now for the motor response, when you are going to assess the patient, for example, if you're going to instruct them, can you close your eyes tightly? If they can follow the command, that is perfect score, 6, right? Or if you are going to ask them to squeeze your hand, if they can do it right away upon prompting, then that will be a score of 6. However, if the patient is going to respond by moving away when you are going to apply that nail bed pressure, painful stimuli, starting with the nail bed pressure, then they're going to move away from that pain. So this is going to be a score of 5. All right. So I hope that you're understanding, Antoinette, about the GCS. I've already explained this in our first section of our neuro lecture. So I want you to go back into that discussion. All right. Again, our answer here this time is letter B, which is 11. Eye opening of 3, verbal response of 3, incomprehensible words, not incomprehensible, or yeah, incomprehensible incoherence, motor function or motor response is 5. Moving away from a painful stimuli. Let's have number 15, guys. A 45-year-old male patient with a severe traumatic brain injury is unconscious and exhibiting poor brain tissue perfusion and significant swelling. Which nursing action is most appropriate? A, encourage coughing. B, position with bent knees and hips. C, elevate the head of the bed. D, group nursing task together. Your patient, a 45-year-old male, severe TBI, unconscious, exhibiting poor brain tissue perfusion, significant swelling. Which nursing action is most appropriate? Will you encourage coughing? Will you position the patient with bent knees and hips? Will you elevate the head of the bed? And will you group your nursing tasks together? You're welcome, Cheng. What is your nursing action here? And just take note about the question. Your patient is unconscious. Read through the question. Unconscious. Will you be able to elicit this one? Encourage coughing? Yeah, we know that this is going to stimulate, right? It will increase the ICP as well. So we are going to eliminate that. But just the scenario alone, the patient is unconscious. Naturally, this is not going to be produced by this patient. So we're going to eliminate that one. What about letter D? Group nursing tasks together. Now, I want you to pay attention here regarding this statement. Group nursing tasks together. So this is basically clustering. If you are clustering tasks together, so this will be quite busy, I should say. You're going to do a lot of nursing care. Multiple nursing tasks for the patient. Guys, be careful about clustering, especially when your patient has increasing ICP or has an issue with ICP. Yes, that's correct. When you are clustering those tasks, this can increase stimulation. Increases stimulation. So it is not recommended for this patient. Should be avoided. Okay? Should be avoided. Never cluster the tasks, because if you're going to do so many things in one episode, in that single rounds, this can stimulate the patients overall, which can increase their ICP as well. So don't do that. So we're going to eliminate letter D. What about position with bent knees and hips? Yeah, elevate the head of the bed. Like I have said earlier, there's none really a specification as to the elevation of the head of the bed, but at least we have that 30, 45, right? Yes. That's the minimum, at least the 30. But there's nothing really a guideline. What exactly is the amount of elevation? There's none. If you would look into every book, every medicine book, there's never a guideline, but at least elevated greater than 30 degrees angle. Okay, so that would be our answer. What about letter B? Position with bent knees and hips. Remember that when you are putting, or let's say you're going to increase the knee gauge, when you are bending the patient's knees or applying the knee gauge, when you're adjusting the bed, this can increase intra-abdominal pressure. Intra-abdominal pressure. Yes, it can. And with that, it can subsequently cause elevation of the ICP as well. So our best action for this patient is to elevate the head of the bed. Letter C. Greater than 30 degrees angle. Okay. Our patient is unconscious, exhibiting poor brain tissue perfusion. Right. Yeah. So this is also incorrect. Let's have number 16. A 22-year-old female patient with a head injury after a motor vehicular accident has clear nasal drainage. What should the nurse do next? Is it A, ask the patient to blow their nose, B, test the fluid for glucose? This is another given question. Letter C, inform the patient that nasal drainage is normal. D, send a sample for lab testing. What will you do here? Clear nasal drainage. What would that be? This is a given. What is your answer? Well, the correct answer this time here is letter B. Test the fluid for glucose. CSF. It is a clear fluid coming from the nose, or it could be coming from the ears. Remember about those oto and also the rhinorrhea? These are signs that there is a fracture going on, allowing the escape or leakage of the cerebrospinal fluid. Okay, so we're going to test that for glucose. Never apply pressure, never occlude the nose, never occlude or pinch or cover, apply pressure into the ear, because this will stimulate increase of the ICP. If you're going to ask them to blow their nose, never do that. It will also increase ICP. If you're going to tell them, inform the patient that nasal drainage is normal, no, not normal. All right. They are having a CSF leak. Letter D, send a sample for lab testing. Do you really have to send that to the lab? Yeah, it can be useful, right? But our priority this time is to check for just the glucose. It doesn't have to be sent to the lab for the glucose testing. You are delaying the confirmation this time. So we are going to eliminate this one. So our answer here is letter B, testing for glucose. Let's have number 17. We're almost done, guys. It's already 2:55 in my time. A 37-year-old female patient with a basal skull fracture is admitted to the hospital. She presents with raccoon eyes, which is the periorbital ecchymosis, and clear nasal discharge. Given the patient's presentation, which doctor's order should be questioned? Is it A, keep the head elevated, B, insert a nasogastric tube for suction, C, turn the patient every 2 hours, D, use cold packs on the face intermittently? So you are given a set of orders, but here you're going to question that order. So which order should be clarified? Yeah, Mary answered letter B, which is insertion of the nasogastric tube. That alone can also increase the tear. It can penetrate the dura mater. Take note about the manifestation here. The patient already has raccoon eyes. They have that ecchymosis. Remember that the battle sign, remember about those? Battle sign, the raccoon eyes. I mentioned about what? Basal skull fracture. There is a fracture there. So you are not supposed to insert any tube because this can further aggravate the tear. Can aggravate the tear. All right. So do not insert the NG tube this time because of the presenting manifestation. They already have those basal skull fracture manifested by the raccoon eyes and clear nasal drainage. So make sure you're not putting anything. Yeah, it can aggravate the tear. If you're going to put the head of bed elevated, yeah, that's a good intervention. So we are not selecting that one. We are selecting that order that can potentially harm our patient. If you're going to turn the patient every 2 hours, that's a good intervention. We are eliminating that one. The application of cold packs on the face intermittently in order to reduce the swelling or the pain, then we can also include that in our nursing care. So never question that one. We are only questioning the insertion of the nasogastric tube placement because of the patient's basal skull fracture. All right, let's move on to number 18. A 22-year-old male patient has sustained a traumatic brain injury and is being monitored in the ICU. Which piece of information about this patient requires the nurse to act immediately, rather? A, intracranial pressure of 15. B, 25 mLs per hour of cerebrospinal fluid drainage. C, 14 mmHg of oxygen in brain tissue, or known as the PbTO2. And D, heart rate of 122 beats per minute on the cardiac monitor. So your patient has a TBI admitted in ICU. So which piece of information about the patient requires the nurse to act immediately? So now we have the PbTO2. What is that PbTO2? Your answer, please. Requires immediate action. Now let's eliminate stuff here. If you had answered intracranial pressure of 15, is that a problem? Is that an issue that you should be reporting to the medical provider? Or is that something that would, not the medical provider rather, is this something that can require you to do something? 15 mmHg. Remember about the value. This is still within the normal range. So this is an incorrect option. Still within the normal range. So eliminate that. Within the range. The normal range. Do not pick this option. What about letter D? Heart rate of 122 beats per minute on the cardiac monitor. Is this going to be a sign that you should act on right away? We know tachycardia 122, it's tachycardia. Anything above 100 is already considered tachycardia. It is a sign of stress, right? It could be a sign that there is pain or maybe other issues, but there is another critical issue that we need to deal with. This is a problem, guys. We know that this is something that you should also take care of. But if you are going to look into the letter B, what is in letter B? 25 mLs per hour CSF drainage. The 25 mLs per hour CSF drainage is considered within the normal range as well. Within the normal range. So we are eliminating this one as well. Now, if you see that your patient has a PbTO2 or oxygen in the brain tissue of 14, this is a significant value. Why? Because the PbTO2 should be within 25 to 50. Okay? Normal value should be within 25 to 50 mmHg. That is our basis that our patient's brain is getting enough oxygen. The value of 14 is very low. This is telling us that there is brain ischemia. Yeah, tachycardia, 122. This is a concern, but it will not place higher concern compared to letter C, which is 14. This is a very low level of oxygen perfusing in our brain. The normal range is 25 to 50 for the PbTO2. Our patient's value is only 14. All right. This is actually very low. So this is going to be our best answer. Letter C. PbTO2 of 14 is a sign of ischemia to the brain tissue. All right. The goal here is to make sure that our patient stays within the range, at least 25, or let's say within the 25 to 50 range, to make sure that they are getting enough oxygen. If not addressed accordingly, our patient will end up with irreversible brain damage. And again, the question is telling us or asking us to act immediately, and that is the PbTO2 of 14. All right, I think this is my last question for the day. Yes, I think it is. So I hope that you are learning from newer concepts today, and please use these important concepts in your future clinical setting and also in the normal range for the PbTO2. PbTO2 normal range. That is 25 to 50 mmHg. 25 to 50. It's right here. Actually, I wrote it already. All right. So, again, thank you for your participation today, and I hope that you are getting your brains exercised today. And hope to see you again tomorrow. We will be dealing with another set of neuro conditions. And yeah, you stay safe and you all take care. I hope to see you again tomorrow. And please don't forget to like this video, share it to your friends who are reviewing for the NCLEX. And again, oh, there's another one, but let's just bypass that. But anyway, I'm encouraging you to enroll into our NCLEX course. Going to the Stancoast NCLEXcoaching.com. And also click into the description box below to know more about our offerings. And please don't forget to hit the like and the subscribe button. This will help us out also in, at least if there is a need for us to do some more live classes, then this will be beneficial for both of us. So please help us out as well. Okay. All right. So let me just answer this real quick. Question number 19. Since we are already looking into this slide, when admitting a 48-year-old male patient suspected of brain injury in ED, which details should the nurse report to the physician right away? Brain injury? Yes, our patient has a brain injury in this scenario, but looking into the options here, daily use of warfarin, blood pressure of 160/92, inability to recall the accident, severe dull headache. Well, this is quite risky, especially if the patient has been using the warfarin, an anticoagulant. If they have a brain injury, all the more that they are at risk to developing massive bleeding. So that is the correct answer for test item number 19. Blood pressure 160/90. It is elevated, but it's not as common. It is not uncommon in an acute illness, and it's not really going to call for a more urgent intervention this time. Inability to recall the accident. This is expected to a patient that has brain injury. So we're eliminating letter C as well. And the same thing with the severe dull headache. Severe dull headache. Take note of the severe dull headache. This is a common occurrence in severe head injury as well. Common. Okay. So our correct answer here is daily use of warfarin. The patient will bleed out. So that is a bonus test question. Again, guys, thank you for your time. I appreciate it. I'll see you again tomorrow. You all take care. Bye-bye.